Good morning, everyone. Thank you for joining us for this session, which we've entitled KDOQI Updates. And the purpose of this session is really to inform you about some of the things that we've been doing at KDOQI. My name is Kevin Tucker. I'm from here in Boston at Mass General Brigham, and I'm the chair of KDOQI. And so we have three very exciting presentations for you this morning. They're going to focus on some of the work that we've been doing within KDOQI. So let me introduce our first speaker, who's going to talk about fall prevention and chronic kidney disease, and that's Dr. Brandon Kistler. Dr. Kistler is an assistant professor in the Department of Nutrition Science at Purdue University. He earned his PhD at the University of Illinois at Urbana-Champaign, where he held a pre-doctoral fellowship from the American Heart Association. He co-directs the Clinical and Translational Nutrition Research Lab, where his research focuses on utilizing lifestyle, primarily diet and exercise, to improve the quality of life and outcomes for people with chronic kidney disease. And he is the newly minted winner of this year's Joel Koppel Award, which was presented to him last night. So, Dr. Kistler, please join us.
All right, so thank you for that kind introduction, and thank you to everyone for showing up today. So here are my disclosures, my learning objectives, and I wanted to start with just a brief poll question, because as we've been going through this, there's not a lot of data, and so I'm quite curious as to what the practices are among the people who are here today. And so if you could scan the QR code and answer the question, do you screen people with kidney disease for fall risk in your clinics? And I'll give everyone just a moment to kind of answer here. All right, and so it looks like we're getting to pretty close to a consistent number here. About 2/3 say no. And then one more question. So if you do screen, or if you don't screen, do you assess modifiable risk factors for falls among people in your clinic who are at risk of falling? Looks like they flipped the answers around here, making sure everyone's awake. All right, so again, it looks like we're getting to a pretty even split, or about 2/3, 1/3, but this time in the opposite direction. And so why are we talking about falls in people with chronic kidney disease? And so I don't think it's any secret that unintentional falls are among the leading cause of fatal and non-fatal injuries among older adults. If you're someone who watches the news, throughout this past year, there have been several high-profile falls from Nancy Pelosi to Mitch McConnell. And so what is a fall? It's unintentionally coming to rest on the ground or at a low level. And as we've mentioned, they're common, the leading cause of fatal and non-fatal injuries. Falls in the US result in 38,000 deaths and 3 million hospital visits. And the cost of treating non-fatal fall-related injuries in the US has been estimated to be $80 billion, increasing from $50 billion in 2015. And many falls are preventable. And so you can see sort of the breakdown of those costs on the right-hand side of the slide. And so we know falls are common in older adults, and there are many reasons to think that perhaps people with chronic kidney disease might be at higher risk. And so protein energy wasting, as we've mentioned, is common in people with chronic kidney disease, and it increases with advancing chronic kidney disease. And so this is a paper a few years ago from a group at the International Society of Renal Nutrition and Metabolism, trying to better quantify that. And the interquartile range for studies that report protein energy wasting is between 28 to 54% of people on hemodialysis. And certainly there are similar numbers for reduced muscle mass and poor physical function. In addition to those alterations in muscle and function, Chronic kidney disease, mineral and bone disorder is common in individuals with CKD. CKD-MBD, remember, is this combination of biochemical abnormalities that generally start around stage 3 of chronic kidney disease that alters bone turnover, volume, and mineralization, and results in increased calcification and potentially increased cardiovascular risk. And so potentially people with chronic kidney disease are not only at increased risk of falls, but also fall-related injuries. And so what does the data say in CKD? And so there are several ways that people have measured fall risk or fall-related injuries in people with chronic kidney disease. One is self-report. And so this is one study that we have done in which we looked at the CDC's behavioral risk factor surveillance system. And we looked at people who self-reported having chronic kidney disease versus people who didn't report having chronic kidney disease. And what you can see is that the odds for both falling and fall-related injuries were higher in people with chronic kidney disease, and as we controlled for several factors, they remained higher. And again, this is in older adults over the age of 65. However, middle-aged adults also fall, but they tend to fall for different reasons. So they tend to fall when engaged in riskier behaviors at higher intensities. And so we also wanted to do a study where we looked at falls in middle-aged fallers. And again, this is self-reported data of both chronic kidney disease and falls. And again, we see higher unadjusted rates of falls and fall-related injuries, but when we account for several factors, only unintentional falls remain significant. Other studies have measured GFR or other markers of kidney function and tried to relate them to chronic kidney disease. And so this is data from the REGARD study in the participants who were greater than 65 years old, who also had Medicare Parts A, B, but not C coverage at baseline. And so overall, 1,103 participants had a serious fall injury, over 47,745 person years of follow-up. The incident rates per 1,000 person years of serious falls were 21.7. My pointer's not showing up. 21.7 and 38.3 at eGFR levels greater than 60 versus 45 through 59 and all the way down to below 45. And so we see with eGFR an increasing incidence, but as you can see in Model 4, this was not statistically significant. However, in the albumin to creatinine ratio, we do see a significant association between increased albumin to creatinine ratio and increased falls. But not all studies have shown this relationship. Again, this is data from, I believe, Taiwan, where CKD was defined as an eGFR of less than 60. However, in the overall cohort, the mean GFR was 84. And the interquartile range was close to 70 to 95. And so there were very few people with kidney disease, and just 1% of people in this study had stage 4 or 5 CKD. Information on falls was assessed prospectively by a falls calendar. So every 3 months, they asked people if they had fallen for a year. And what you can see is that in the people in that cohort with CKD versus non-CKD, there was no significant results. So not all studies show this relationship. But if you look at a systematic review, there is a general relationship between decreasing eGFR and the odds of an unintentional fall. However, because of the ways that they've been reported, they weren't able to do a meta-analysis to show this statistically. And so people with non-dialysis CKD may be at increased risk for falls. But what about dialysis? And so here's some data that would suggest that the initiation of dialysis increases fall risk. And so this is a retrospective cohort of claims data from the 2-year period, 1 year following and 1 year before the start of dialysis. And so annual rates of serious fall injuries were 64.4 and 107.8 per 1,000 patient years, so a drastic increase. And so the incident rate ratio was 1.62 for the time following dialysis versus the time prior to dialysis. There's also minimal data comparing dialysis modalities, and so this is a retrospective cohort study in patients over 18 years. And you can see on the left-hand side of the slide an unmatched cohort, and the right-hand side seeing a propensity score match between people on dialysis and people in peritoneal dialysis. And so on the left-hand side, you can see that the unadjusted incidence rates were significantly higher in people on hemodialysis, but when propensity scored match, that was no longer the case. So again, people on kidney replacement therapy, especially dialysis, appear to fall more often. Well, one of the things we're particularly interested in with falls are the incidence of fall-related injuries, which are commonly fractures. And so this is data from Sharon Moe that appeared in C-JASON, where they drew data from several sources. And one of the things that you can see as you go from left to right, as age goes up in not only the general population, but in the different stages of CKD, so too does the incidence of fractures. But what you can also see is that as CKD advances, we also see elevated risks of falls. And in fact, 2 to 100 times higher incidence of fractures compared with age and sex-matched individuals without CKD. Here's another systematic review and meta-analysis of the rates of fractures. And again, as you move down from the top of the slide to the bottom of the slide, you see reductions in eGFR, advancing chronic kidney disease, and what you can see is a significant increase in the rates of, in this slide, hip fractures, but also in general fractures as well. And so fractures increase with decreasing GFR and appear to be highest in dialysis. And so given that information, it might be of interest to try and prevent falls. And so there are several guidelines that exist from various organizations on how to prevent falls. Organizations like the World Health Organization, the CDC, Geriatric Society, and most of these fall prevention guidelines follow a very basic path. That we should screen patients for fall risk. Among patients who are screened at increased risk for falls, we should assess them for modifiable risk factors for falls. And if they are positive for some of those modifiable risk factors, we should intervene with the appropriate evidence-based method to reduce fall risk. And so there are several validated screening methods for fall risk. These tools vary in several areas. So the number of questions range from 1 to 20 questions. How they're administered, some are self-administered and some are administered by the clinician, and also by the inclusion of functional assessments. The CDC recommends 2 tools. One is the Stay Independent, which is a 12-question screening tool. The other is the 3 key questions tool, which is perhaps the easiest to implement. And here you can see those 3 key questions. Do they feel unsteady when standing or walking? Do they worry about falling? Or have they fallen in the past year? However, none of these have really been tested specifically in people with CKD. There are also several modifiable risk factors for falls that are common among people with CKD. Some of those are intrinsic, things like advanced age, previous fall, muscle weakness, gait or balance problems, as well as poor vision and postural hypotension. And some of them are extrinsic, relating to the environment. And so there are several environments where people are more likely to fall. the home, the hospital, and potentially one that we could look into is the hemodialysis clinic. And so there are several tools available to both assess risk in environments, specific environments, as well as with information on how to intervene in those environments. There are also several evidence-based fall prevention programs, but few of these, if any, have been tested in CKD. And so I just want to make you aware that there is a National Falls Prevention Resource Center, and it provides a list of all fall prevention programs and materials, and it's generally kept up to date. And so when we think about fall prevention programs, we generally think about multifactorial fall prevention programs. Some of the most common include a matter of balance and the Atego exercise program. Multifactorial fall programs are going to include address multiple areas, such as fall prevention education, exercise-based programs, or home modification, among others. Most of these are free. So for example, I'm at a land-grant institution in Indiana, and land-grant institutions have extension. Many extension programs run these fall prevention programs in the community and will take referrals, oftentimes free or for reduced charge. So what have we actually done in chronic kidney disease to try and prevent falls? Despite the evidence suggesting that people with CKD may be more likely to fall and more likely to have a fall-related injury, a recent meta-analysis looking at fall prevention strategies in CKD only identified 5 studies that have looked at this, and the vast majority of those used exercise in one form or another in dialysis. And so this is one example. This is a study that took 69 independently ambulating hemodialysis patients above the age of 70 and randomized them to exercise or standard care. The exercise was 30 minutes of intradialytic aerobic exercise coupled with 4 resistance training exercises that were done with a band. And they followed these patients for almost 3 years. And what you can see on the left-hand side of the slide here is that in this very small study, they had 10 fall events. 9 of those fall events were in the control group, and just 1 was in the exercise group. And so that was statistically significant. When they looked at fractures, I believe they had 4 fractures roughly, 3 fractures in this study, and they were all in the control group. And so this is a study that would suggest that perhaps exercise could be an effective strategy in people on dialysis to prevent falls. One of the more interesting studies, I think, performed a routine root cause analysis in their outpatient hemodialysis unit. So this unit noticed an increase at falls in their unit. And so as part of a quality assurance measure, they looked into these. They did root cause analyses for all of these falls. And so you can see the factors that they identified on the left, the fact that they have a high-risk patient population. They had a scale that was was higher than the ground, so an elevated scale. They have had poor lighting, wet floors, and a lack of a supportive device in the patient restrooms. And on the right-hand side, you can see the interventions that they undertook to address each of these factors. They also, based on their analysis, developed a fall risk assessment for their in-center use that they could use to identify patients that were at increased risk of falls. And so with this targeted intervention, they were able to significantly reduce falls. And so it resulted in a significant reduction in the combined incidence of both patient as well as staff or visitor falls from 22 per 100,000 treatments to 3 per 100,000 treatments after that intervention. And so I think I'm going to end with just a little bit of time left over here. But in summary, people with non-dialysis chronic kidney disease may be at increased risk for falls. People on kidney replacement therapy, especially dialysis, appear to fall more often. Fractures increase with decreasing GFR and are the highest in people on dialysis. That's across all age and sex groups. Despite several validated fall prevention programs, most work in CKD has been done in dialysis. It's involved small studies of exercise, usually by itself, or as I showed you in one case, an environmental adjustment. And these results, as I showed you, seem to be promising but are inconclusive. And there are several gaps that exist in the literature. And so in particular, looking at falls among younger adults. So almost all of the studies are in adults over the age of 65, and especially looking at the circumstances that surrounding falls, that are surrounding falls. So understanding where people are falling, why they're falling, are they tripping, are they slipping, because those things are ultimately going to affect what are going to be the most effective ways to intervene and prevent falls. And so our work is ongoing, but I want to thank all of the people that are working in this work group. And with that, I will open it to questions.
Thank you, and I'll invite people who have questions to come to the podium. But I'll start with the question, and that is, you mentioned that there are several tools, like questionnaires, but also functional assessments. Functional assessments, particularly in the hemodialysis unit setting, are obviously more difficult to do. So how much do we know about how well these various tools perform? Are questionnaires equally as effective in identifying those who are at high risk of falling as a more functional assessment?
So there are, not in CKD or hemodialysis specifically, but there are several systematic reviews who have tried to look at this. And in general, the results are inconclusive among the different fall screening tools. But there are, again, several fall screening tools that have been validated and shown to be effective, but comparing them, the results are just inconclusive.
And do we know anything about what happens in terms of fall risk after someone receives a kidney transplant? Does the fall risk go away, or are they still left with a higher fall risk?
So the evidence for falls in transplant is incredibly limited. I believe there are 2 papers, and falls were not the primary outcome. They were secondary outcomes in those studies. And the numbers were quite low. So I don't think we quite know what happens in transplant. But if I had to speculate wildly, I would suggest that it probably reduces fall risk.
Thank you. Please introduce yourself and ask your question.
Hello, good morning. Kimberly Zitko, I'm PharmD Geriatrics trained pharmacist. I was wondering if you could expand a little bit for the group on the top medications that you see as high risk in this patient population for falls. Thank you.
Yeah, so a great question. And for many years, a lot of the data on that focused on polypharmacy. But in recent years, the literature has moved more towards suggesting that specific medications are what contribute to increased fall risk. And so anything that alters cognition is generally on that list. Antidepressants are probably the highest, but also, we have a lot of patients on antihypertensives. And so hypotension is, I think, an under-recognized cause of falls in this population. I will say one other thing related to medications. I think one particularly high risk time is in transitions to care. And I think that that's potentially a place where we as an organization can work to make sure that medications are communicated clearly in the various transitions to care between hospitals and other facilities.
Yes, sir.
Duncan Johnstone from University of Kansas. I was wondering about any attempt to unite 2 different areas with the use of anticoagulation, Coumadin and DOACs for AFib still, to me, is pretty controversial among dialysis patients, and it's awfully common. And if you or anyone you know has ever sought to address fall risk specifically in that group, because that's when I'm more often begging repeatedly to have my patients stop their chronic anticoagulant when I can see a high fall risk in my patient.
So I will say I'm not a pharmacist, so I don't want to hop too far out of my lane, but what I would say is that the American Heart Association actually very recently published guidance on fall prevention in people with cardiovascular risk factors, and they addressed arrhythmias and medications and several medications as well. And so I believe that they address something along those lines in that paper.
So, Dr. Kistler, we know that the hemodialysis unit is one of the highest risk areas for falls, and you use the word lane, so I'll use that term. So whose lane does this belong in? So we think about the multidisciplinary team. You are a trained dietitian and an expert in falls. So does this fall in sort of the lane of the dietitian, the social worker, the nurse, the physician? Who should sort of be taking the lead, do you think, or in terms of our thinking about fall risk and trying to make sure that, since we know that the dialysis clinic is such a high risk place, that we're assessing fall risk and thinking about it appropriately?
So you're going to put me on the spot. That's obviously the way that many people have handled this is multidisciplinary teams. Many dialysis units have risk assessment. Nurses have led several fall prevention programs. And so I think it makes a lot of sense to have a lot of people involved. Social work, again, to make people aware of community resources that can help prevent fall risk. Postprandial hypotension is a cause of falls as well. So even my home area of dietitians could be involved in this as well. But if you're asking me who's probably ultimately going to lead it in the dialysis unit, it's going to be a medical director or a physician is probably how it'll get the most traction.
Thank you very much for an outstanding presentation, Dr. Kistler. So one of the other areas that KDOQI has been interested in is really thinking about nutrition and cultural sensitivity and nutrition guidance. And to help us think about that, we're delighted to have Dr. Csaba Kovetsky from the University of Tennessee tell us about cultural sensitivity and nutrition guidance. He is the Fred Hatch Professor of Medicine and Chief of Nephrology at the University of Tennessee in Memphis. He earned his medical degree from the University of Pest in Pest, Hungary. He completed his residency in internal medicine at Henry Ford in Detroit and his fellowship at Johns Hopkins Bayview. His research interests are centered on disease mechanisms and outcomes in patients with pre-dialysis CKD and ESKD. His research involves clinical trials, observational analyses of large administrative databases, and translational research experiments in patients with all stages of kidney disease. So, Dr. Kovetsky, thank you for joining us today.
Thank you, Dr. Tucker. I appreciate the kind introduction, and it's really a pleasure to be here to talk about a very interesting topic. Nutrition is really close to me. I have to say that this talk centers mostly on qualitative research, which is not what I usually do. I'm used to hazard ratios and numbers, and this will be a lot of what people think and along those lines. So here are my disclosures. The objectives, three main lanes here. We will look at significance of nutrition and nutrition interventions more as a general thing. We will review what challenges are faced by patients and their caregivers when it comes to nutrition interventions. And then we will describe some approaches to encourage the adoption of nutrition guidelines. So the importance of food was already emphasized by the father of everything in medicine. Hippocrates in ancient times floated the idea that that food is really medicine. And indeed, when we look back at how important nutrition is, it is really one of the most important risk factors globally. About 11 million deaths are linked to poor nutrition, accounting for about 20% of all deaths. And these are primarily related to chronic diseases that are linked to nutritional deficiencies or imbalances, such as cardiovascular death, diabetes, cancers, and so on. In the US, about 45% of deaths are linked to cardiometabolic diseases that are related to poor diet. So switching to chronic kidney disease, you saw this map from Dr. Kistler. This is the ISRNM meta-analysis of protein energy wasting globally. It's clearly something that affects essentially all of our patients. And there on the right side, I'm just showing the non-dialysis dependent CKD studies, which show that on average about 20% of non-dialysis dependent CKD patients suffer from protein energy wasting, and the number is about 40% on average in dialysis patients. So clearly, malnutrition, or as we like to call it in nephrology, PEW, protein energy wasting, is a very common problem. Now, when it comes to sort of a global therapeutic approach to patients with CKD, this is specifically for those with diabetic kidney disease here, we're all in love with the bottom part of this ADA KDOQI recommendation, i.e. all of these fancy newer medications, and rightfully so. You know, this has been a tremendous advancement of our therapeutic armamentarium. And we should aim to implement these medications on all of our patients. But I'd like to point out to you that something we don't talk about very much is the lifestyle modifications, which are still on top of this chart, specifically healthy diet. It should really be front and center for every patient, bar none. So with that, the updated KDOQI guidelines from 2020 on nutrition was really way overdue. I mean, it was about 20 years prior to this that we had a systematic assessment of nutrition in CKD and ESKD. And it offered some important new features, such as recommendations on the overview of personalized nutrition care, updated recommendations on protein intake, energy and macronutrient balance, various macro and micronutrients. A new thing, relatively new thing, is plant-based diets, low-protein diets, fluid and micronutrient considerations, and then integration with healthcare teams. So, an ARS question here to see how much you retained from the previous section. What proportion of patients with non-dialysis dependent CKD suffers from protein energy wasting? So you can use the same method you used before on Slido to indicate your preferred answer. Okay, so we're in the right ballpark, let's put it that way. Most people got the average, about 30% right, so it's about 20% for non-dialysis dependent patients, about 40% for dialysis patients, so the average is 30%. So I'll give you a pass. I'm being generous today. Okay, so what are the putative benefits of a nutrition intervention, as we like to call it, medical nutrition therapy in patients with CKD? Okay, so on top of it, most people's minds is a delay in CKD progression, because that's what's generated most of the literature. And it's probably also the most controversial, because overall, you could say that the effectiveness of this intervention is controversial. There are studies that were not statistically significant. Overall, we do have recommendations about that. But it still generates some debate, and some people question the effectiveness of it. But let's not forget that there are scores of other benefits that are very practically important. Okay, reduction in uremic toxicity, very, very important. A lot of stuff comes from diet, and by approaching patients with a a proper diet recommendation, you could avoid excess burdens of water, sodium, potassium, phosphorus, so on and so forth. All of these are linked to adverse outcomes. And you can decrease accumulation of breakdown products from proteins and avoid metabolic acidosis, again, uremic toxins such as phenols, indoxyl compounds, advanced glycated end products. So all of those are biochemical benefits, but they are really something that we pursue as therapeutic targets in our practice. A separate one is prevention of malnutrition. Again, not talking about excesses, but talking about deficits. Again, very important, as malnutrition markers are very strongly associated with poor outcomes in this population. And then there's this big group of quality of life that's related to how patients transition to dialysis. So on the one hand, by implementing a proper diet, you can delay the need for dialysis because you will have less volume excess, less uremic burden, less uremic symptoms with a proper diet. You could also allow more time for placement of an AV fistula during this time, again, portending better prognosis down the road. And again, after dialysis transition, if you have a better control of your volume and symptoms, you may be able to do twice-a-week dialysis, a relatively new concept, especially in the US where dialysis is industrialized. There are several clinical trials now that test this hypothesis that most patients transitioning with residual kidney function are able for some time to do twice-a-week dialysis instead of 3 times a week dialysis. And nutrition and proper diet can be part of that approach. So now let's switch to this big area of qualitative research and examining patients' experiences, what are their difficulties, and what approaches can healthcare providers foster to implement healthy diet choices in this population. In general, we could say that patients perceive CKD diets to be challenging. And I'm going to show you an interesting thematic analysis. It's a qualitative study in about 26 patients with various stages of CKD and also 11 caretakers to illustrate the journey that the patient goes through during this period. So one theme is that they feel that it's overwhelming, frustrating, and it's an emotional journey, diet being so central in anybody's life, okay? Also, they perceive the diet to be complex and challenging. Importantly, a dietitian's input is highly valued by patients and caregivers. Okay, they help navigate these complex and challenging issues. The importance of somebody who cares, and this is usually a spouse or a significant other. Although I have to say that when I was a fellow in Baltimore, we had a wealthy patient who bought his own personal chef to him to get dietary advice from the dietitian. So that may also be important. And then moving into how patients solve this, they like to develop problem-solving strategies as a separate team. And then they express the desire for additional resources and support. So clearly, you can see how patients value this and their priorities. So review of available literature going along those same thematic analyses. This reviewed about 40-odd studies for a total of more than 800 patients. About half of these patients were on various forms of dialysis, and then the rest were sort of divided between transplant and non-dialysis patients. And you can see 2 large groups here. So on the one hand, you have the things that are perceived as burdens and challenges, and then you have the positive adaptation problem-solving part as patients move from those challenges to how do they solve those. And 3 main themes under burdens. One is preserving relationships. So when you start imposing these restrictions and recommendations, there's sometimes interference with existing roles. There are social limitations. There's the burden that's being perceived. There is also fighting temptations. Obviously, this is perceived as an imposition on usual tastes and what people like to eat. It's a mental invasion, and people oftentimes initially at least they don't like that. So then they move to navigating change. How they feel deprived. They have to break their habits and norms. They are overwhelmed by information. Sometimes they question the efficacy of these interventions, and then they have to negotiate priorities. So all of these requires a lot of teaching and hand-holding and navigation help to move to the positive adaptation, which basically results to optimizing health. They will accept responsibility, value self-management, and recognize that this is preventing disease progression, and then it helps them to prepare them for transplant, as this is ultimately basically the desired kidney replacement therapy choice. And finally, they become empowered. They are able to comprehend these paradoxes, and they find solutions, and they master change. So this is a very nice way of going from the burdens to the adaptation. So that's in the literature. So now to dig into what challenges our patients face, and then what solutions can we have. And I like this approach. This is the so-called socio-ecological approach to describing challenges, especially challenges, and then the successful implementation of diet. This is like a Russian doll as you go from, broader areas to more granular areas. So you start with individual barriers, then you go to family barriers, health system-related barriers, and then finally community and policy-related barriers. So let's examine these individually, one by one. So what kind of individual challenges do our patients perceive? And I'm giving you really a high-level summary of what was published in multiple papers here. One problem is limited health literacy. This obviously depends on the area, but most of us, or many of us, practice in areas where our patients are really, I have to say, some of my patients can't even read. So it's something that we have to be cognizant when we try to educate them. There are personal beliefs about diet and reluctance to change their dietary habits. Obviously, diet is something that we live with from the day we're born, and you develop a certain attitude towards it, and now you walk into a nephrologist office and they tell you suddenly that you have to upend everything that you ate before. There is fear of omitting nutrients. There is a lot of stuff that you get from social media and everywhere, and especially since some of our recommendations, or many of our recommendations, focus on limitations or restrictions of what people should not eat. You have to contend with this idea that they think they will be malnourished or undernourished. There's also fear of limiting social interactions because of these impositions. And then specific to physiology of CKD and ESKD, there may be taste aversions. It may steer them away from what they should eat due to degustatory changes. And then specific, especially in dialysis patients, is fatigue, which sometimes can reduce the intake, just moving out to eat, and in general intake. So how about the family-related barriers? Most people, or many people, live within families, and they may not be the ones cooking. So their intake is really influenced by whoever prepares their meals, what their skills are, what the facilities are, what their budget is. And again, going back to this patient of mine who brought their chef, very few patients have that luxury. So oftentimes we definitely encourage them to bring their significant other, especially I practice in the VA, so most of my patients are male. They usually come with their spouses who cook in the home. So it's very important to educate not only the patient, but also the person who prepares the meals. Food insecurity is unfortunately still a common theme, even in developed countries. So preaching about what they should be has to be put in the context of what they can afford to eat. And that, for example, that also leads to some patients eating pre-prepared meals, ultra-processed foods, so the healthy choices sometimes are not attainable due to these issues. Then there are the health system-related barriers. Okay, a common one is the limited access to appropriately trained clinical practitioners, and in this context, really we're talking about trained dietitians, and I preferably would say trained kidney or renal dietitians, because this is really such a specific entity that expecting a patient to go to a general nutrition clinic, my personal experience is that oftentimes they talk to them about obesity and diabetes control. And the fine points of kidney nutrition are really ignored in these general visits. So I value my renal dietitian tremendously. I do have one that's a luxury, and I can send them for really high level training about kidney specific diets. But a a global assessment indicated that in lower income countries, 90% of them have a shortage of proper dietitians. And that's also common in middle income and even in high income countries, where a third of high income countries describe a shortage of proper dietitian resources. And here in the US, we're pretty well off in the dialysis units, but access to dietitians in pre-dialysis stages is patchwork, so not all the clinics can afford that or provide that. In part due to inadequate reimbursement or high patient demand or both. So clearly there's a very high number of patients, and it's probably not realistic to have every patient with CKD interact with a renal dietitian. There's clearly a problem there. Shortcomings in nutrition education, clearly a problem. This is in part due to shortages. Oftentimes a patient may end up with just a brochure or a pamphlet, and that can be daunting, especially thinking back at their individual limitations. Maybe they cannot read well enough and they don't have the proper education to understand. So proper counseling really involves a in-person back and forth to assure that the patient comprehends the information, and avoid things like unintentional weight loss and malnutrition, because a well-intentioned approach that is not individualized and not properly monitored could lead to improperly low intake of nutrients. Just to underscore the point of how difficult this is, there was a meta-analysis in 2017 that indicated that the adherence with renal diet was only 31%. Protein intake specifically was examined at 45%, but with renal diet in general, only a third of patients were able to stick with those recommendations. And obviously, specialized dietetic support is something that has been shown to help promote self-efficacy and confidence. So let's see what kind of community and policy-related barriers are our patients facing. Well, one thing is food labels, and this is something that's been examined a whole lot. There are still holes in that. Potassium and phosphorus, I don't think we still have these on labels in the US. This varies among countries. Some countries do show them, but this contributes to the challenging nature of eating food, because if a physician tells them to restrict potassium or phosphorus, they need to be able to assess where those come from and how much the food contains. Restaurants, also something that may or may not be present. So I'm always amazed visiting children in California, the amount of information you get there. But then, we crossed into Utah on a trip, and my wife's vegetarian, and we walked into a restaurant, and she asked, what kind of vegetarian items do you have? And this guy stared at her blankly, and he said, none. Okay. They didn't even try, so. Other community and policy-related barriers is the food deserts. Obviously, you're very familiar with that in inner cities and also on the countryside. Low income, these are a problem because patients will have trouble gaining access to proper nutrients. And then, there is this, I like to call it the California thing, environmental concerns about packaging and sustainability and ecosystem management. So again, differing in various geographic areas, but some people may have this as a priority. So let's talk about some of the approaches which we could encourage to adopt proper nutrition recommendations. Okay, very importantly, we have to encourage a culture of nutrition screening. Okay, it's oftentimes depressing for me to practice in the general nephrologist setting, because I have to say that 80% of my colleagues don't regard nutrition as something that's a priority or at the forefront of their thinking. Again, we talk about blood pressure, we talk about SGLT2 inhibitors. But at least, pay attention to some glaring things, a low albumin, a patient losing tremendous amounts of weight. So these are very easy to identify and can lead to at least a referral. I tell my fellows, I don't expect you to be a trained nutritionist, but I expect you to recognize a malnourished patient and at least refer them to a nutritionist. Very important to do this on an individualized basis. So we recognize that our patients are very complex, some of the most complex patients that healthcare providers will see. And there is this interconnectedness of all of these conditions, metabolic conditions, kidney conditions, cardiac conditions. And all of these interventions have to be done in the context of all of the individual characteristics of a patient. Talking about that general approach where you only talk about diabetes, you can't do that. You have to be able to recognize that if in a diabetic you restrict caloric intake, you may cause malnourishment in a patient with CKD or ESKD. So there are these things that are very important to identify. And then importantly, you have to be patient. Okay, this is a very complex journey, a long journey, and has to be a lifelong adjustment. So you cannot have a one-time brief session. There has to be a back and forth where you will assess adherence and you will encourage the patients to maintain these dietary habits over a long time. Timely access to specialized dietetic expertise, I think we discussed that. This is very, very important. Physicians simply don't have the time to do this properly, even those who believe in it or have the background knowledge to do it. A general nephrology visit may be anything between 15 to 30 minutes and has to address all of these other priorities, from blood pressure to metabolic control to various medication intervention, GDMT, so on and so forth. So nutrition, at least I'd like to encourage my colleagues to screen for it and refer, and then our dietitians to do the time-consuming evaluation of what a patient's eating, and then initiate the intervention as needed. Again, the referral to renal dietitians. And then, interestingly, if supplements are available, that usually comes up separately in the literature. In some ways, you could consider that increasing the complexity of the intervention, but in some ways, it may actually simplify it. So there is actually experience with these low-protein diets, which if you implement it on the background of a supplement such as keto analogs, it may actually increase liberalize the food intake part. So it's sort of an interesting take, but definitely the type of nutrient, the supplement, and the amount of it will have to be directed by a trained person who knows how much and what kind of intervention to pursue. Very, very important, okay? The advice should be focusing on foods and not nutrients. And clearly, we eat food, we don't eat nutrients. So if I tell a patient to consume 0.6 gram per kilogram per day of protein, might as well forget about the whole thing, okay? So the interaction with the dietitian, where they talk about what foods do you eat, how much do you eat, and give them viable alternatives that are food-based, okay? Not talk about the average amount of protein and energy, okay? Foods that can be eaten more than foods that have to be avoided. So again, positive messaging, okay? A common theme, first-year fellow will tell the patient, don't eat bananas, okay? That's the potassium restriction, okay? But then the patient walks and said, what should I eat, okay? So talk about what they can eat, how much they can eat, not what they should not be eating. A food plate model is a good one. This is a hardcore dietitian thing. It facilitates understanding. Teach your patients to read food labels. And then portion sizes, very important, especially in the US. You go to cheaper restaurants, they will serve you so much food that it's probably 3 portions in one meal. So learn not to eat everything, and in the context of a meal. Local cuisine elements are very important. I lecture on diet in Asia, and they showed me their cookbooks. I didn't understand a single word of it. Okay, so it's very important. The food is very local. Okay, so again, the importance of having trained professionals locally who know that if you go to the market, you will find X, Y, and Z, and how do you eat in that context? And that has to be done in the context of the cultural and social environment of a certain area. And then again, emphasizing regular follow-up to maintain adherence. We mentioned that this is really a long-term relationship between a nutrition specialist and the patient. So that was it. In summary, we discussed some general concepts about nutrition deficiencies and their link with poor outcomes. We mentioned the guidelines, then the challenges that patients are facing, and then various strategies that can be used. I recognize this was a lot of text, but I hope that it was helpful. Thank you very much. Happy to answer questions.
Thank you, Dr. Kovesti, for a very great presentation. I invite you to come to the microphone if you have questions, but in the meantime, there are a couple questions that have come up in the app. And the first is, do you refer your patients to a dietitian based on eGFR or only when they develop hyperkalemia or hyperphosphatemia?
Yeah, very good question. It would be very nice to refer them based on eGFR. I would like to do that, but I can't. It's a resource problem. I'm actually blessed to have one dietitian who serves the dialysis unit that we have in the hospital and all our clinics. So we have to be, judging based on her availability, and hence we refer based on indication, which would be any kind of nutritional imbalance. So this could be malnutrition related, this could be overnutrition related. Occasionally patients will request it, and we're able to accommodate that. So some patients express strong interest, saying that, hey, I want to know what to do diet-wise. But more often than not, it will be a hyperkalemic patient, a hyperphosphatemic patient, or a patient who's losing weight.
So a sort of related question is there a benefit to having patients establish a relationship with a dietitian early on before developing electrolyte imbalances or weight loss?
Definitely. Obviously, it's better to prevent something than try to extinguish the fire when it's already there. One initiative that we had in our hospital was a kidney kitchen, where people could sign up. Again, it goes to patients who have an interest to do this, but it would be a useful way to teach people and patients and caregivers about basic elements of basic techniques that they could use in the context of CKD and the related abnormalities.
Is there a protein restriction, or do you recommend protein restriction in CKD, non-dialysis, and protein restriction in patients with end-stage kidney disease?
Yeah, so this is a very complex question, obviously. So I'm going back to the KDOQI and the guidelines, which recommend the protein intake of around 0.6 gram per kilogram per day in your average stable, non-catabolic patient with no acute illness. And that's based on a lot of physiology, and many studies have been done. You're familiar with KDOQI coming up with a very abbreviated recommendation of 0.8. So somewhere between 0.6 and 0.8 is probably a sensible way of recommending protein intake. I need to make a comment on the term restriction, because physiologic studies have indicated that 0.6 to 0.8 gram per kilogram per day is sufficient. It's actually the ideal amount of protein that a healthy body needs to live freely and enjoy life. Unfortunately, the average protein intake in a modern society is much higher. In CKD patients, it's somewhere around 1.3 gram per kilogram per day, so about twice the necessary amount. And there is scores of data to suggest that there are many potential harmful effects of that amount of protein intake. And hence this term protein restriction comes from the recognition that the actual intake in many patients is more than necessary, and the necessary amount is a restricted diet. Now, you will hear naysayers, especially pointing out the MDRD study, which was the mother of all nutrition studies, unfortunately showing a negative outcome due to a variety of issues. Other things that are brought up is the difficulty of implementing it, quality of life, and so on and so forth. Usually where we can agree is that if we individualize the approach, I think we can find common grounds to avoid excessive protein intake. Clearly if somebody has measurable and notable adverse outcomes, adverse effects of excess protein intake, such as metabolic acidosis, hyperphosphatemia, hyperkalemia, that needs to be restricted. And hence, rather than being extremely prescriptive and sticking to 0.6, which could be difficult to an individual, you find some common ground there to avoid complications and to get them to a point where they can still enjoy life and enjoy their diet, but avoid the harmful effects of excess protein.
Can you comment on the interplay between chronic kidney disease and obesity, balancing nutrient needs and weight loss goals?
Yeah, so we're taking the tour de force here of everything nutrition related. So yes, obesity, you're aware that ASN came out with a guidance document recently on what to do with obesity. On the one hand, obviously, on a general scale, obesity is the bane of our society. It's responsible for a lot of chronic illnesses from, cardiovascular disease, diabetes, cancers, and so on, and also kidney disease per se. So incidence and progression of kidney disease is worse in adipose individuals. What makes this a very interesting and challenging question in patients with advanced stages of CKD and ESKD is that, at least in observational studies, excess adiposity and obesity has been linked to better outcomes on the short run. And we're talking about probably energy stores and the advantages over like a very limited outlook, a very limited time span where you don't develop atherosclerosis, but you may be able to better survive a septic episode, something like this. So in that context, weighing the pros and cons of weight loss interventions really becomes challenging and has to be individualized. You may hate this word, but this is where we are, in the sense that consider that a weight loss intervention may lead to about 25% of the lost weight coming from muscle. So the development of sarcopenia, sarcopenic obesity, the adverse outcomes related to it, falls for one, and a lot of other things with loss of muscle mass. So that has to be considered. And then consider the pros of losing adiposity. Clearly, improving somebody's chances to get a transplant is a big one. I don't think anybody questions that if we consider that, then it should be pursued, but it has to be pursued in a way that takes into consideration overall health and the impact on the patient's outcome. That's really very abbreviated. We could talk for an hour about this.
So I'm going to take moderator's privilege and ask the last question, because the title of the session is really about cultural sensitivity. So I'm from Alabama. You're practicing in Tennessee. And we love our greens and our tomatoes. And so we often talk about the things that patients shouldn't eat. But yet those are often some of the most nutritious foods, and they're non-processed. So how do we balance, healthy diet with avoiding the things that patients should not eat? Can we be more liberal with our diet, given that now we have newer drugs that help us to control potassium?
Yeah, so specific to greens and tomatoes and fresh food, I think nobody questions that this is your healthy diet. If you have a patient with normal kidney function and cardiovascular risk factors, this is what you want them to eat. It's the DASH diet and similar diets, Mediterranean and so on and so forth. And, perhaps a misperception that all vegetables or fruits will lead to high potassium. That is an oversimplification of this. It's much more complex than that. For one, the amount of fiber contained in these foods can be actually helpful to diminish the hyperkalemic effects. The alkalinizing effect of a fruit vegetable-based diet also diminishes hyperkalemia-inducing effects. So I think it's possible to steer patients towards a healthier diet with proper guidance. If you avoid potatoes, that's probably helpful. Avoiding the healthy, greens may not be so much. Again, dietary advice and somebody knowledgeable about it. Leaching, for example, can decrease potassium intake, potassium impact from these foods. Boiling them in cold water, starting with cold water. And then the use of binders, of course, that's a more novel aspect of this intervention, where clearly it hasn't been proven in clinical trials. Unfortunately, there was a trial in dialysis called the GRACE trial, which was initiated to show that the administration of one of the novel potassium binders can lead to a healthier, maybe more liberal diet, but the trial petered out. It was unable to recruit. Having said that, in the context of, for example, enabling RAS inhibitors, we have been successfully using these potassium binders, and you could conceptualize that in a person who eats these kind of healthy foods, especially seasonally, you may be able to get them through that time with some as-needed binders, perhaps.
Great. Thank you so much for a great presentation.
Thank you.
So our final presentation is going to be from Dr. Lekha Tumilapalli. She's a nephrologist and health service researcher at Weill Cornell Medicine. Her research examines value-based payment and healthcare delivery strategies to achieve high-quality care for patients with kidney disease. She's going to be talking about something that we've been working on a lot here at KDOQI, and that's education. And so, Dr. Timopali, welcome you to the stage.
Good morning. It's really a tremendous privilege to be here to talk about NKF's efforts to develop a core curriculum for CKD education. So thank you so much to Dr. Tucker for the opportunity. These are my disclosures. So today's learning objectives, we're going to review evidence for CKD education, and we're going to articulate some strategies that the NKF is undertaking to standardize a core curriculum for CKD and how this standardized curriculum may enhance the quality of delivered care. And then we'll discuss some considerations for CKD education, how we can incorporate that into potential regulatory strategies, such as a quality measure or accreditation, or some other strategies. So I think, before we talk about CKD education, a prerequisite to education is awareness. And so if a patient in clinic is receiving CKD education, they need to have the context that, I myself have CKD and that I'm aware of my own CKD before I can understand the context of that education. And so we know there's major gaps in CKD awareness. This is the latest data from the CDC's kidney disease surveillance system. This is among CKD stage 3 to 5, and awareness is about 25%. It has increased over the past decade, and it depends on the question being asked. This is work from Delphine Tuo and Chi Chu. The NHANES question asking about awareness is weak or failing kidneys. If you ask about a kidney problem, awareness is higher. And awareness does correlate with the KDOQI heat map. So people with albuminuria, later stages of CKD, are more aware of CKD. So that is a good sign. The most severe patients are more aware of their own CKD. And so moving to CKD knowledge and its treatment options, we know there are major gaps in this area. So many survey studies at single centers. There's actually very good understanding that patients know that there are stages of CKD. This is asking patients some validated survey questions like the KICS survey. So actually 90% know that there are stages of CKD, but only about 20% knew reasons why protein in the urine was a problem. And then when asked about various knowledge of different kidney functions, and then symptoms of progression or kidney failure, knowledge was very variable. So about half of patients knew the various types of kidney functions in terms of bone health, in terms of anemia, and then variable knowledge of symptoms of progression as well. And notably, there's a much better understanding in terms of treatment options of in-center hemodialysis compared with home dialysis and transplant, as well as conservative kidney management. So I thought the study was really interesting. It asked patients that were established in CKD clinic, when you do dialysis at a hemodialysis center, about 2/3 knew that would take 3 to 5 hours a session, but when they were asked to complete the sentence that peritoneal dialysis can be done at home, only 1/3 of patients knew that peritoneal dialysis could be done at home. And these are patients that were already kind of looped into care. And then moving from education to decision-making, so part of the modality education that we're giving to CKD patients is that they need to make a decision in terms of their modality choice. And there's major gaps in shared decision-making around that decision. And so when CKD patients were asked on this shared decision-making scale, that the MD and I selected a treatment option together, the minority of patients agreed with that. So less than half said that they selected an option together. And then when asked about that, the physician explained the advantages and disadvantages of the treatment options, about half agreed with that. So they didn't feel that they had an adequate understanding of the advantages and disadvantages of the various treatment options presented to them. So there's really good evidence for CKD educational interventions. So this was a systematic review that found 26 studies of CKD educational interventions there were 12 randomized trials and 14 observational studies, 5,000 participants. So a lot of data that we have that establishes that CKD educational interventions are effective. And they were found to be effective in increasing quality of life scores like EQ-5D, increasing knowledge scores like the Kidney Knowledge Survey or KICS, increasing self-management behaviors. So this included self-reported diet behaviors, exercise behaviors, and medication adherence. And then some evidence for clinical endpoints as well. So some biochemical markers, LDL, blood pressure control, and some mixed evidence about EGFR decline. So we know that education is incredibly important across all stages of CKD, but the majority of this talk will focus on education in CKD stages 4 and 5. So we know we need upstream education, which the majority of those patients are seen in primary care settings. If we focus on CKD stage 4 and 5, if we're thinking about how to standardize the education and implement these interventions, we're thinking more in the nephrology setting. And we know that many of these educational efforts occur in multidisciplinary care clinics. So these care clinics have a variety of different care practitioners, including nurse practitioners, dietitians, social workers. This was a systematic review of, it found 38 studies of multidisciplinary care clinics. The average team size was 4 to 5 people, and not all the multidisciplinary care clinics for CKD included social workers and pharmacists, but the majority of them did include nurses and dietitians. And so structured education within multidisciplinary care is very effective in improving optimal starts, optimal transitions to kidney failure therapy, as well as home dialysis and preemptive transplantation. So this is just data from 2 programs in New York City, including our own at the Rogosin Institute, the Peak Clinic, showing that the structured education, we have one clinic where the education is led by a nurse practitioner and one by a nurse, is very effective in improving these optimal starts in home dialysis and preemptive transplant rates. And more evidence that CKD educational interventions are effective. So this was a educational intervention paired with a decision aid. And this was a randomized controlled trial recently published in Annals of Internal Medicine of the DART study. And so patients viewed a 1-hour treatment options for kidney failure video, and this significantly reduced decisional conflict. And so they were, the quality of decision making, they felt more prepared in terms of their choice of types of dialysis modality or conservative kidney management. So with all this in mind, we've reviewed the gaps in CKD education, as well as the considerable evidence for CKD educational interventions. KDOQI convened the scientific workshop, which was convened prior to the NKF Spring Clinical meetings earlier this week. Many of you in the audience were in attendance, and this scientific workshop was defining a core curriculum for stage 4 and 5 CKD patients. And so this workshop was led by the co-chairs, Sherry Rivera and Dr. Kevin Tucker. And the aims of this scientific workshop were to develop a plan to engage diverse stakeholders in creating the standardized core education curriculum, to prioritize guiding concepts for curriculum development, and confirm the content of the curriculum, and establish future working groups in order to drive this curriculum forward and potentially implement it into policy and regulatory changes. And so this was really conceptualized by the KDOQI leadership, which, and really the brainchild of Dr. Carrie Willis, the Chief Scientific Officer of KDOQI, as well as organized by Jessica Joseph and the Workshop Planning Committee. And so all of these national and international experts in CKD education were convened on this planning committee to plan this scientific workshop. So today, during this talk, we're going to go over an early look into this workshop. The full workshop proceedings will be published in the final consensus report, but we wanted to give you an early look of what was discussed and some of the considerations that we're thinking about here. So I'll walk you through the day of the workshop and everything that transpired. So first was a panel of patient perspectives on CKD education, and these included 3 individuals with lived experience on in-center hemodialysis, peritoneal dialysis, and transplant. Many of these individuals were diagnosed very, very early, some in their pediatric years, and they really centered our conversation in terms of the gaps of CKD education. So some of their direct quotes is that they told me it was time for dialysis. That's what I was told. I was not given other options. And they said, if you have any of these symptoms, go to the ED and then we'll put a line in you. He said, someone should have thought about preemptive transplant. That was not brought up at all, so I ended up on dialysis. And there was some desire that they wished that they would have been shown videos showing the steps. They wanted to know what a graft looks like in real life, a fistula looks like in real life. So after this, very centering patient panel, we heard from Dr. Corinne Bagnes from France about this consensus conference that they convened in Europe in 2013. And this was answering a lot of the questions that our scientific workshop aimed to address as well. So they had this consensus conference on quality standards for pre-dialysis education. And so this is detailed in this publication. And so they convened 5 participants, 5 nephrologists from different European countries, and they conducted a survey and reviewed what the current guidelines in each of the European countries as well as the US said in terms of who should be on the educational team, as well as what knowledge, training, and experience should the team have. And they also suggested minimal quality standards as well as optimal quality standards. So should the core curriculum be kind of a set of minimum standards, or should it really be aspirational? So the consensus, both from the guidelines as well as their expert opinion, was that the CKD educational team should be a multidisciplinary team with at least 1 physician. And it outlines, the various knowledge and training and experience the team should have about adult education, interviewing, communication skills, avoiding bias, and then patient communication. They also discussed when should pre-dialysis education occur, and pre-dialysis education meaning not necessarily that all patients would pursue dialysis, some would pursue conservative management, but the consensus was that it should occur at least 12 months before developing kidney failure. And another consensus was that it should be individualized education. So while group options are available, that there should be some individualized and individual sessions, and it should be delivered over 2 to 6 sessions. So the next talk was from Dr. Karen Layden, and she reviewed the current educational tools that are already in existence. And so this was a very detailed talk that reviewed all of these educational tools that many of you use in your CKD clinics already. So this included the NIDDK Kidney Disease Education Program, Kidney School from Medical Education Institute, AAKP has educational materials, DaVita Kidney Spart, the DART program, which we reviewed the randomized controlled trial, materials from the National Kidney Foundation, and then Fresenius Kidney Care. So you can see these are a mix of types of material. In terms of the delivery method, there were written materials, online modules, videos, some were in person, so a range of delivery methods. The primary focus was also different, so some were focused on broad CKD education, some were more early stage and late stage, others were focused more on late stage and more on dialysis modality education. The target audience also slightly differed across these, whether the target audience was patients and caregivers versus older adults, and then had various benefits. So some were commercially developed, some were in trusted free resources, and then had drawbacks as well. So some were static, only the written materials, only PDFs, they were not kept up to date. And so reviewed these various pros and cons of these existing CKD materials. And then our next talk was from Joanne Rinker that was very interesting because we compared the status of CKD education compared with diabetes education. So diabetes has a very robust educational program in terms of certified diabetes educators. And so they have national standards that are delineated in this Diabetes Self-Management and Education and Support National Standards publication. And so this publication reviews the timing of diabetes education, which it should be at diagnosis as well as at hospitalization and at any change in disease status. And to compare CKD education versus diabetes education, again, CKD currently does not have any structured standards versus diabetes education has standards for the timing of the education as well as the content of the education. Both CKD education and diabetes education have reimbursement through Medicare. So there's a Medicare benefit, kidney disease education, the KDE benefit, and then diabetes education has a reimbursement as well, the diabetes self-management training reimbursement. KDE, there's some differences. KDE, we can bill up to 6 sessions versus diabetes self-management, they can bill up to 10. And both can be individual or group-led. In terms of accrediting the educator, so who is delivering the education and do they have any standards for their training and their knowledge, or is there any accreditation test? So in CKD, there's no accreditation of the educator, versus in diabetes education, they do have a structured certified diabetes care and education specialist that's the renamed certified diabetes educator term. And then in terms of a knowledge assessment for the patients, a lot of our participants said that we are delivering CKD education in various ways in our clinics, but we're not assessing the comprehension and retention of our patients. Versus in diabetes education, one of the standards is that you should use validated instruments or assessment tools to assess how the education was, how effective the education was. And so just some more details about these certified diabetes educators. These can include RNs, RDs, or pharmacists. They must undergo diabetes-focused education of first direct patient care of 1,000 hours within 5 years, providing this education to people with diabetes. They must have a continuing education requirement and then also receive a passing score on this exam. And there's a five-year renewal cycle. So then we convened 5 breakout groups. And so I'd like to go through each of the breakout groups and what they discussed and some of the evidence that they deliberated on. And so breakout group number 1 was about educating and evaluating the educator. So who is going to deliver the education and how are we going to train them? And so things that were discussed in this breakout group included who would actually educate the educator. Some of those materials could come from NKF because it's an objective, trusted source, and they could actually set the standards. There could be a train the trainer model. A formalized structure was needed, so there was some enthusiasm for a more formalized structure to identify who is the educator and how they are trained. And some examples included a cancer care model or a potential kidney disease center of excellence. And then in terms of educating the educator, a lot of enthusiasm for digital platforms or telehealth and delivering it in a decentralized manner. So breakout group 2 was tasked with the very daunting task of selecting and prioritizing the curriculum topics. And so they again reviewed some of this, the systematic review of the 26 studies, and this was the various content that was included in all of these 26 studies of CKD educational interventions. And so you can see in the randomized studies versus the non-randomized studies, some differences, but thinking about content in terms of kidney disease physiology, diet, pharmacologic and medical protocols, nutrition, counseling, lifestyle, exercise, medication management, self-management, blood pressure, nutritional needs, psychosocial, and then information on dialysis modalities as well. This group also reviewed some of the pros and cons of existing educational tools as well as their content. So this was a study led by Dr. Karen Layden, looking at educational sessions, and they did direct observation of various CKD educational sessions and looked at the content of the education. And they found 5 content gaps. And those gaps included mental health and cognition, diet and financial costs, advanced care planning, and decision support. And so sometimes education was given, but in the context of providing support on decision making, that was viewed as a gap. And additionally, when reviewing the content of these educational tools, they often did not adhere to health literacy best practices in terms of a lot of use of medical terminology and undefined terms. And so this group has come up with some potential criteria to consider when selecting educational components. And so that includes safety. So, primarily we want to provide advanced guidance to patients on how they can stay safe. And so if they do have symptoms where they need to go to the ER, we provide anticipatory guidance. And so that includes, various safety elements. And then the level of evidence as well. So when selecting education, the level of evidence of the guidance. And so, for example, if there's not a good level of evidence for that intervention in CKD, we could provide some information about that to the patient, but that might be lower priority to include in the educational content. And then alignment with personal life goals, so what they want to achieve with the therapy. And there was concern about depth versus breadth, so this trade-off that if we include everything in the core curriculum for CKD education, we might not be able to cover it in as much depth. So breakout group 3 was focused on curriculum delivery, and so identifying the most effective methods for delivering the curriculum. And again, returning to the systematic review, different considerations included one-on-one versus group delivery, face-to-face versus slide lectures, counseling interviews, telecommunication, written materials, and then whether it was a teaching method of didactic versus goal setting versus one-on-one discussions, and then the frequency of interventions as well. And so this was a nice commentary that reviewed some of the evidence behind this that shows that teaching sessions that are interactive have goal setting that is integrated. They're multidisciplinary group approaches. They include family and caregivers, so they involve them, and they use digital media and frequent sessions. Those were found to be particularly effective. So breakout group 4 looked at the evaluation process. So after we deliver education for our patients, how do we measure whether that education was effective? So how are we currently assessing this? So in part, it's assessed on the 2728 form. So as patients are initiating dialysis, we ask the nephrologist, does the patient indicate that they received and understood options for home dialysis, for kidney transplant, and not starting dialysis at all, active medical management without dialysis? But there's some limitations to this. So the nephrologist starting the patient on dialysis might not be the one that was seeing them in CKD clinic, and they might not know whether the patient has received this education. And so when thinking about measuring the quality of the CKD education, we can return to our Donabadian model. So these are various things that we could measure. We could measure whether the clinics had adequate staffing for education, whether they were accredited to provide education, whether the clinic had certain types of providers. We could measure knowledge pre and post in the patients. We could just do a checkbox measure. Did the education occur? We could measure decisional quality. We could measure whether they build the KDE, and then we could measure self-efficacy and patient activation. Or we could look at more downstream clinical outcomes like blood pressure control or even hard outcomes to measure whether the education actually made a difference in their clinical outcomes. So I think there was some thought that measuring clinical outcomes down the road was too far removed, and we might want to measure something more directly like knowledge or decisional quality, but there was also concern about increased burden on CKD clinics in doing this assessment in terms of the amount of paperwork needed. And so breakout group 5 looked at aligning incentives for quality and reimbursement models. And so now that we have this core curriculum developed and we want to implement it, how do we integrate that into policy change to maximize the impact and implementation? And so one of the existing tools is the KDE benefit. These are the CPT codes used for individual and group sessions. You can bill up to 6 sessions. It's limited to CKD stage 4. It can't be billed for CKD 5 or dialysis. There's efforts from the NKF to try to increase the scope of this benefit by expanding it to CKD5 and dialysis, as well as expand the number of providers that can provide this education. So right now it's just nurse practitioners and nephrologists, but they would like to expand it to allow nurses to deliver the KDE as well. And we don't know the utilization of the KDE, but it's less than 5%, and there's no recent data, but actually old data suggest it was only 1% as of 2014. So only 1% of patients with CKD are actually receiving, of eligible patients with CKD4 are actually receiving this benefit. There are some guidance for the KDE benefit in terms of what the education should include. So we can borrow from what already exists when forming this core curriculum. And KDOQI has convened this quality measures committee to think about whether CKD education could potentially be a quality measure, assessing whether nephrology clinics are providing education and the quality of such education. And so this is again led by Dr. Tucker and Carrie Willis and the members listed here. There is only one current Medicare quality measure about education. So it's in the MIPS program. That's a mandatory pay for performance program for physicians, including nephrologists. And so there is this education quality measure for support of caregivers for patients with dementia. So they're measuring the percentage of patients with dementia whose caregivers were provided with education and were referred to additional resources. So to summarize, KDOQI has convened this scientific workshop, and we look forward to sharing the proceedings of the workshop and the conclusions about this core curriculum. But really multi-level interventions are needed to improve CKD education quality. And so with patients, we need increases in health literacy, health numeracy, and trust. For providers, a lot was discussed. How do we educate the educator? Should we have curricular standards? Should we have accreditation? The practice settings, thinking about staffing, hiring a CKD educator, you would need practice buy-in, and then thinking about the incentives and funding for that. In terms of the payers, public and private, expanding the KDE benefit and looking into whether a quality measure has a role here. And then for purchasers and professional societies, developing those standards from trusted sources like the NKF, and on the population level, improving CKD awareness, like the awareness campaign. So really want to thank you and take any questions.
So we're a few minutes over time, but for those of you who can stay, there were a couple of questions that have come in the chat. Can you say anything about the videos that patients viewed on renal replacement options? Are those freely available, and were they accessible to people who might not have access to technology?
Yeah, the DART intervention developed at Tufts with Dan Wiener and Karen Layden is freely available on the website.
And is anything being done to address the need for earlier patient education?
Yeah, NKF has multiple initiatives to improve CKD education in primary care, like CKD Intercept, many engagement, primary care engagement initiatives.
So thank you, Dr. Chimilipali, for an excellent presentation, and thank you all for joining us this morning.